So our next speaker is joining us online from London. It's a pity you couldn't make it, Professor Makin, but I'm sure we'll enjoy your lecture nevertheless. Professor Tamar Makin is at Imperial College London, and as you can imagine, she's been doing some work on phantom limb pain as well. So I'll give you the floor, Tamar.
Thanks, Max. Just to say, I'm actually from UCL, not Imperial. So I hope you can hear me and see me okay. I'm really sorry I can't be there in person. What I thought I'd like to start with is pointing you to a recent global survey about treatments for phantom limb pain as practiced by clinicians from around the world. And what is of notice from that survey is of the 7 treatments that reached consensus across clinicians, 6 of them were non-pharmacological. And if we look at these treatments, mirror therapy, graded motor imagery, sensory discrimination training, virtual reality training, and to a small extent, even potentially functional prosthesis, all of these treatments are really focused at restoring or at least normalizing the missing hand representation. And based on these current treatments, if we take a look into the near future, when we are trying to develop new neurotechnologies in order to extend treatment, in order to make it more accessible to patients across the world via AR, teletreatments, all of these treatments are really focused and trying to restore the original homunculus, as Jack described, or re-engage the motor circuits of the missing hand, as Max highlighted. And these technologies, may potentially do us good because they might reduce the reliance on medication. But at the same time, I think at this point, before this stuff really takes over, we must take a pause and consider very, very seriously whether these technologies can actually have the potential to influence the mechanisms causing phantom limb pain. So a lot has been said already on brain reorganization, and specifically Jack has already highlighted the seminal study by Merznick from '84 showing that if you amputate a digit to a monkey, here is the middle finger, the cortical territory of digit 3 gets taken over or subsumed by the cortical neighbors, digit 2 and digit 4. A further study by Pons and colleagues has demonstrated that if you deafferent the entire upper limb of a monkey and you record receptive field properties from the neurons in the cortical territory of the deafferented hand, this is responses from the lower pace are registered in the sensory territory of the hand. So based on all these and similar evidence, it has been established that amputation of the hand leads to cortical reorganization by the cortical neighbors that take over the freed up cortex. Inspired by these findings, Herta Floor and her colleagues have demonstrated that cortical shifts of the lower part of the face, and there was a lot of focus specifically on the lips, correlate very substantially with the extent to which the participants report experiencing spontaneous phantom limb pain, as she's just highlighted in her talk. Based on this and a lot other converging evidence, this maladaptive plasticity theory has been established where sensory deprivation due to input loss following amputation would trigger cortical reorganization, and this cortical reorganization would therefore subsequently trigger phantom pain. We are all aware that this error is a bit vague in terms of causal mechanism, but the theory goes that there's a mismatch between the architecture of the area and the new inputs associated with the reorganization, and this might trigger some error signals that would be experienced by patients as pain. And because all of this mismatch is happening within the territory of the missing hand, it will be experienced as pain coming from the missing hand. Now, look, I've spoken vocally and will continue to speak vocally against this theorem. But there's one really great thing about this theory that we have to acknowledge and have to respect, which is it provides very clear predictions, very clear criteria to either approve it or diffused. And specifically when it comes to phantom pain treatment, this theory argues that if we want to treat phantom pain, we need to either reverse this cortical reorganization or undo the sensory deprivation. And this is where mirror box treatment and all the other therapies that we've been hearing about over the last couple of hours come to mind. So the idea is that we're trying to reinstate the representation of the missing hand, reversing sensory deprivation, reversing maladaptive cortical reorganization, and reversing phantom pain. Now, to cut a very long story short, I don't think when reviewing the literature, we have any strong evidence that these treatments are working. Not currently, not based on the published evidence. And this is because for every paper you would pull out that argues that there's some benefits specifically for a given treatment, there'll be another one saying that the level of evidence underlying that paper are problematic, and then another paper not being able to replicate the original findings. So I really think that if we pull all the evidence together, it doesn't add up. It doesn't look promising, not clinically. But what I wanted to do with you today is go over some of the basic assumptions, mechanistic assumptions, that are underlying all the current and future treatments that are non-pharmacological. Sensory deprivation leads to cortical reorganization, leads to phantom limb pain. So going back to sensory deprivation, as you've seen from Herter's talks and other, in order to probe the territory of the missing hand, there's been much focus on the cortical neighbors, mainly the lower face, but also the stump. But if you are interested in understanding what happens in the territory of the missing hand, why not take advantage of phantom sensations? This is an old trick. Rafin, who will be talking after me, was the first to demonstrate it with fMRI. Let me just show you what happens in the brain when we're asking an amputee to move his phantom hand. So here you can see someone moving their intact hand, just to show you how hand representation normally looks like in the sensorimotor cortex. And next we're going to ask the same participant to move his phantom hand. So not much is happening up on the screen, but if you look at the brain, you can see this cortical activity signature that looks to me as an fMRI expert very much like typical hand representation. This is from our first study, just demonstrating that if you ask people to move their phantom hand, pretty much each and every one of them is able to engage the territory of the missing hand and elicit some specific activity with the sensorimotor hand territory. Stanley Kicker, the former student in my lab, has taken this a step further by investigating the topographic property of this persistent representation. So this is a 7 Tesla study where she's asking here just one control participant, for example, to wiggle around his regular biological fingers in the scanner, one after the other. And what she does here is she constructs this finger map by looking for selectivity gradients, so areas that respond more strongly to one finger being moved compared to the others. This is the central sulcus, postcentral gyrus, so we are safely within primary somatosensory cortex here. And this is just a technique that allows us to uncover representation of individual fingers and finger maps. Here's an amputee performing the same tasks, this time with his phantom hand. He's been amputated for over 30 years. When we're scanning him, he has a high level of amputation, so no more muscle normally controlling the hand. And yet, when he's wiggling his phantom fingers about, we can uncover with these selectivity maps a whole complete representation of his missing hand with the phantom thumb, index, middle, ring, and pinky. So when we amputate the hand, we don't just wipe out the representation of the hand. Dan Vesselenk, another former student in my group, was interested in understanding whether this persistent topographic representation of the hand is a correlate of vividness or ability to move the phantom fingers, or kind of a more canonical feature of hand representation in amputees. So he used a different approach, a representational similarity analysis, which is a brain decoding approach. What he does here is delineate the somatosensory hand area, and then compare the activity patterns associated with movement of individual fingers. So here we have the thumb, the index, the middle, the ring, and the pinky. And the further the dots are from each other, the more distinct or separate or different the representation is across fingers. And as you can see within this representational space, neighboring fingers on the hand are represented more similarly which is a distinguishing characteristic of the topographic hand maps. Here we have 17 amputees with an average of 18 years since amputation. Except for all of them being amputees, they had very little else in common. Different times in amputation, level of amputation, phantom sensations, phantom pain, phantom vividness, prosthesis usage, hand dominance, anything you can think of. And yet, on average, we can very easily, very clearly dissociate the presentation of one finger from the other, meaning the information content of the hand is still there. But more importantly, we identify this canonical representational structure of the fingers in the hand, with neighboring fingers on the hand, or the phantom hand now, represented more similarly to each other. And this feature, this representational feature that makes this area, the hand area, and not the face area or lip area, or I don't know what area, this functional feature was also preserved in the few participants that we had that couldn't feel their hand anymore. So it seems to us that any person who used to have a hand and lost it, at least as an adult, to amputation, would retain a representation of the missing hand. Hunter Schoen, a current student in my lab, is interested in understanding whether this persistent representation of the hand is just kind of some residual or fundamental feature of the network properties in the somatosensory hand area, or whether the phantom representation actually stores the unique experiences that have been collected by the unique experience of the hand before it was lost. And to answer this complicated question, he's been working with patients that are about to undergo hand amputation. So the patient that you're seeing here is struggling with a slowly progressing tumor in her arm bone. And by the time she is scheduled for an amputation, she's already sustained pretty serious damage, both to the tissue and the nerve. Meaning when we're asking her to move one finger at a time, she can do it no problem in a healthy hand, but she does struggle with an unhealthy hand. Accordingly, when we look at the finger maps that are retained here, so these are just simple winner-takes-all map over a mass territory of the somatosensory hand area, we see a nice pretty representation of the healthy hand and a much more messy representation of the unhealthy hand. We can still make out some index, middle, ring, and pinky, so we can still make out the whole hand, but it's not as pretty as we like to see. The interesting question for us is what's going to happen to this not so pretty map following amputation? Is it going to fall in line or become tidy because the flesh and bone restrictions are no longer there? Or would it retain the experiences of the unhealthy hand prior to amputation? The answer is the latter. I'm just blowing this up for you so you can see it more clearly. If you compare the pre-amputation to the post-amputation map, qualitatively you can see that the specific features of the hand map are exquisitely preserved following amputation, meaning that hand amputation doesn't reduce or change or unengage or makes the hand representation disappear. Not in primary somatosensory cortex, not in primary motor cortex. So going back to the maladaptive plasticity theory. Sensory deprivation triggers cortical reorganization, triggers phantom pain. We would expect that people that have more of this persistent representation should have less cortical reorganization, therefore suffer from less phantom pain. But as Herta mentioned, this is not what we find. This is our original study, this is our replication study. We've actually replicated it in a couple other studies. We find whenever we look at persistent representation, that it positively scales with phantom pain. So people who suffer from worse phantom pain, and we use chronic measures of phantom pain. People who have worse chronic phantom pain show greater activity within their missing hand territory when they're moving their phantom hand. And to us, this reminds us of peripheral contributions that may engage the same pathway both for pain and for some other sensation. So to summarize so far, according to the textbooks that I think most of you have grown up on, I certainly have, phantom pain is triggered by maladaptive reorganization. Therefore, in order to treat phantom pain, we need to reverse this reorganization. We find that the hand representation in sensorimotor cortex is alive, well, and kicking. There doesn't seem to be any severe deficit There doesn't seem to be a need to reinstate or restore the original representation or re-engage the motor network. It's all working fine. So this is about sensory deprivation. What about cortical reorganization? I think you know where this is going to go. If there's no sensory deprivation, why would there be cortical reorganization? But let's look at the evidence. So the easiest analysis for us to do is grab activity level in the territory of the missing hand, sensorimotor cortex, or primary somatosensory cortex, and see how much activity we can pick up when we're asking participants to move their lips. The prediction would be that people with amputation should have reorganization, therefore more representation of the lips, and that this should scale with phantom pain. But this is not what we find. We don't find any evidence for the lip area going into the hand area. We don't find any statistical relationships with phantom pain. Now, some of you might think this is a cheap shot because Herta has never shown the lips go into the hand area. Again and again, she shows a shift, which might be subtle and might reflect more subtle excitation and inhibition changes in the cortical neighborhood of the hand, which brings us to looking at shifts or distances. So we are focusing on geodesic distances that take into consider the unique topology of individual participants, so how much they're folding. I think there's no argument that this is the superior and potentially only way to measure cortical shifts. This is from our original study. We identify for each participant, amputees in orange, control in purple, the center of gravity of the lip representation. These are lip movements. This is the central sulcus. And what we find is a very, very, very small potential shift of the representation of the lips of the amputees. But really importantly, this is within the cortical territory of the lips. The representation of the lips doesn't seem to kind of pour into or towards the hand area itself. Most recently, Vicky Ruth and Dolian Moret, which are training in my lab at the moment, have run a truly heroic study trying to separate representation of different facial parts. Vicky is going to tell you more about it in her talk on Thursday, so please tune in. But one summary results that I like to emphasize here is that, again, using geodesic distances, large samples of participants, lots of controls, we don't find any evidence for reorganization of the lips or of the forehead. So we cannot find any evidence for shifts as reported by other groups. We're very happy to make our data available. I believe we have made some of this data available before, but if there's any third party who would like to analyze the data, we'll be more than happy to give it to them. So to summarize, so far, textbooks tell us that brain plasticity is determined by cortical neighborhood. We find very little evidence for reorganization by the face, both lower and upper. And we'll talk about the upper limb in a second, but I can tell you we don't find reorganization there too. So as Herta pointed, why are we looking at this passive potential for reorganization when there's so much scope for reorganization based on adaptive behavior? And you know, from the dawn of neuroscience, when we think about LTP, we don't just think about input, we think about synchronized input that is consolidated within a given context that is meaningful. And adaptive behavior is just that. We're dramatically changing the way we are using our body in order to achieve a purpose. For example here, how do you open a bottle of water with just one hand? So as you can see in these videos, there's a range of potential solutions to this problem. And what we find is that people spontaneously develop their own motor repertoires in order to solve this problem. We've done extensive research in individuals that were born without a hand, so congenital limb difference. They, like the amputees, only have one hand and have one stump. And what we found is that the various strategies that they use in order to compensate for being born without a hand correlate or associate with how much or what patterns of reorganization we found in the territory of their missing hand. So that when we ask them in the scanner to move the residual arm, their lips and their feet, we compare activity between the congenital in different participants and controls, we find activity in and around the missing hand cortex. And this is irrespective of the homunculus boundaries. It doesn't matter if it's a cortical neighbor or not of the missing hand cortex. So by this same logic, the same rationale, it's interesting to ask whether amputees can also evoke remapping based on adaptive behaviors. So this is by now a pretty old study. We have provided amputees and individuals with congenital limb differences accelerometers that they had to wear on their arm, residual arm, and intact hand. And with this technique, we can just measure how they go about the day and how they use the upper limbs in coordination or synchronization with each other. And what we find is that congenital limb different participants are very good at incorporating the residual arm in daily tasks by manually. And we've done quite a bit of research on that. The amputees, on the other hand, they have an intact hand, they know how to use it, and they overuse it. So they rely on it a lot for compensatory strategies. Now, based on this result, behavioral result, we can predict that congenital one-handers should show overrepresentation of the residual arm, whereas acquired amputees should show overrepresentation of their intact hand on which they rely on more, and maybe this should relate to the territory of the missing hand. And this is exactly what we find. So in both sides here, we have activity levels within the territory of the missing hand. On the left, we have residual arm movements. On the right, we have intact hand movements. And what we find is that the congenitals who rely on their residual arm show increased activity for their residual arm relative to controls, relative to amputees. Not amputees. Amputees do not show increased activity for the residual arm, so they do not show remapping of the residual arm. Whereas if we look at intact hand activity, we find that in amputees, there's very strong ipsilateral activity. So when they're moving their intact hand, they're engaging their missing hand cortex much more than controlled and congenital. We've replicated this effect multiple times. And this is really important when you're running studies on mirror box and other treatments, because when you're moving the intact hand, you are activating the missing hand cortex. So please bear that in mind when you're interpreting these findings. Summarize so far. Body parts that are used for substituting hand function may potentially be potent triggers for brain reorganization. If this is the case, what about artificial limbs? After all, they are specifically designed to afford patients to substitute for the missing hand function. Here we're going to take a little break from sensorimotor cortex to the back of the brain, occipital-temporal cortex, visual cortex, when we and others have shown that there exist areas that respond selectively to upper limbs as opposed to other body parts or object categories. And by the way, in the context of is the visual representation normal or not, it is totally normal. We have lots of data showing no differences in visual representation of the hands between amputees and non-amputees. But back to our question here. How do amputees represent artificial limbs? So we show people pictures of cosmetic and functional prostheses, as well as upper limbs, biological upper limbs. We also throw in tools because tools tend to dominate these visual areas. And we use brain decoding to ask first in control participants, how is the representational structure of prosthetics look like relative to these categories? So here, the shorter the branch, the more similar the activity patterns, the more indistinguishable the representation is. And as you can see in control participants, the cosmetic prostheses are represented like biological hands, sorry, whereas the functional prostheses are represented quite differently to hands and instead are represented more like tools. What about prosthesis users? So this is the summary of 32 prosthesis users. Half of them are with congenital indifferences, the other half are acquired amputees. We do not find differences between these two groups when it comes to these visual representations. What we find is that both the cosmetic and the functional prostheses are represented much more like each other and much less like a hand, also less like a tool. So there seems to be this plastic change in the representational structure of these categories in visual cortex, such that prostheses are represented more like a separate category, distinct from the anchor categories. And I should mention this was scaling with prosthesis use. So people who use the prosthesis more actually show more of this plastic shift of representation of prosthetics away from hands, away from embodiment, and on towards its own unique representation. For the 1 minute I have left, I just want to convince you that adaptive behavior is a potent driver of plasticity in sensorimotor cortex. And now we're going to look just for a minute at healthy people using a prosthesis This is a prosthetic fed thumb specifically designed for augmentation, that is to extend the motor repertoire of able-bodied participants. And with this technology, we ask people to use the thumb for semi-intensively for 5 days. And we're interested in understanding how the abrupt change in how people use their own biological hand is going to impact the hand representation. So we're comparing the representation of the 5 fingers with this brain decoding technique, representational similarity analysis, before and after the 5 days of training. And what we find is summarized here. There is a very subtle but definitive shift in the representational structure of the fingers following 5 days of training, indicating again that adaptive use, adaptive behavior is a potentially potent, powerful modulator of brain organization. But the bottom line is that that cannot be just passive. It has to come in context, it has to be meaningful, it has to be consolidated. So my conclusion is that missing hand representation persists. I don't know why all of you are trying to reinstate the representation when it is there, and I haven't seen any evidence that is abnormal in any meaningful way, both for the sensorimotor system, but more importantly, for the pain system. And secondly, it doesn't mean that we should give up on plasticity. It means that we need to learn to harness it, because plasticity, I believe, is adaptive and related to meaningful behavior. So I want to very briefly thank everyone in my lab who has been slaving over these ridiculously difficult studies to run, and remind you all to wear a mask. Thank you.
Thank you, Professor Makin, for this presentation. And we have a few questions for you. And I will start with a question that I have myself, actually. So, and it's a rather long one. There is a bit of introduction. So, there is evidence, there is a lot of evidence regarding the fact that in a healthy subject, there is a strong correlation, positive correlation between activity in the motor regions and the motor output, meaning muscle activity and contraction force. And also there is increased bolt activation when there is more fatigue, right? So if you have a task, a functional task in which you use phantom motor execution to map, to do functional mapping, then the problem would arise when, as you found as well, like in your lab, that there is a strong correlation between motor execution, worse motor execution and phantom limb pain, right? So patient with phantom limb pain would have worse control and would have also slower movement, correct? So then, like, I wonder, like, the increase in bolted activation that you found, wouldn't it be a reflection of worse control rather than a reflection of a correlation to pain or a relationship to pain?
We actually account for that in our experimental design. So what we do is when we put participants in the scanner and we ask them to perform the movements, we adapt the movement to the patient's ability. So if they don't have much ability to move the hand, or if it's hard for them, they perform micro movements and they perform them more slowly, so that the emphasis for us is not so much on executing the movement, but attempting to execute the movement. And when it comes to the representational similarity analysis, which is a far more sophisticated approach, we completely get rid of these issues, because there's a bunch of studies showing that the frequency or the speed or the difficulty of the movement doesn't impact the representational structure.
All right, thank you. So there are a bunch of more questions. I'll take the next. What are the difficulties with studying lower limb phantom limb pain and most neuroscience studies? Because most neuroscience studies appear to be in the hand instead.
Yeah, well, I mean, from my perspective as a neuroimager, the feet take a much smaller cortical territory than the hands. And the only study we've done with feet required us to go for 7 tests on neuroimaging in order to allow us to get sufficient spatial resolution. Another, for me, reason not to use the feet is that it's far less detailed, so we don't have detailed finger representations or toe representations. In the foot area, the connectivity with other areas is less clear. And then, of course, a lot of the function of the feet, locomotion and so on, is actually, you know, governed by subcortical structures, which wouldn't necessarily be, you know, easy for us to study or image.
Okay, thank you so much. We have to stop here with questions, and we will keep them for the panel discussion.